Let's talk a little bit about the financial side of this, which is, the escalation in cost sharing in the last 15 years has been astounding, how quickly it's happened. I mean, it used to be $200 deductible was a big deductible, and today anything less than $1,000 is considered a deal. So, I know, Bruce, you've actually done some studies on this, and have a pretty strong view on what's happening here.
Certainly, from the standpoint of healthcare utilization and costs, we know that lower income individuals, which effectively account for about half of the U.S. adult population, tend to delay, defer, forego care for the sake of cost. And that's in the face of this increased prevalence of high deductible health plans and high deductibles. And that is certainly not favorably impacting overall health. And I think some employers, unfortunately, have misinterpreted their data to think that a reduced healthcare cost trend is equivalent to improved health status, when in fact it's a consequence of people avoiding or delaying care.
Yeah, and I know, Pat and Andy, that both of you have actually recognized this issue in your own strategies, and frankly are in some ways ahead of the curve in adjusting your strategies around this. Maybe Andy, you could start. And
yeah, sure. So I think as you look at the impact on lower wage employees, people more in the entry level, we differentiate the premium that they even pay for the plan. So lower entry, an entry level position will pay less for the same plan than an executive will. But then also, as we contribute to the health savings account or anything like that, that's based upon somebody's grade level too. And so the entry level person gets more funding in that health savings account than the executive does too. So to offset that impact of going to get the right care, especially the episodic care or the chronic care type of thing, we've tried to factor that in and feel pretty good from our data that it is impacting that and not negatively impacting someone's ability to go get the right care.
And Pat, they're not your employees, but
No.
but it's a very mission-driven population, and I know it's actually part of the charter of the Presbyterian Church to take care of these people.
It is.
How do you reflect that in your approaches to support them on benefits?
Well, first, we've been very slow to pick up on high deductible health plans. This is the first year we've actually offered it to our employers as a choice that they might use to offer to their employees and pastors. So our basic program, which is a PPO, people would call that, wow, you still have a PPO. Yes, we do. And probably 80% of our members are still enjoying the benefits of a fairly rich PPO to begin with, but the deductibles themselves are all income indexed. So there are 10 different deductibles and they're indexed to annual incomes.
And I know in the culture of the Presbyterian Church, shared mutuality is a key value. And
what's good for one part of the body is good for the entire body.
Yeah.
And so it is a community, and the community supports each other.
Yeah, and so I think a lot of this really kind of comes back to rethinking this in the context of your values and your talent strategy more broadly. Right.
But Mike, I want to come back to that point. I think there's another issue which a lot of employers just haven't addressed, and that is value. And where is the value in improving the health of the workforce? And as much as there may be a shared value in providing these more equitable health benefits, I think employers also have to start to look more at what the value is to the organization and how, for example, is someone who is selling insurance or a pastor who is supporting a congregation made healthier by accessing equitable benefits in a way that allows them to do their job more effectively.